Let's talk about one of the most serious surgical emergencies in spinal surgery, Cauda equina syndrome. This is one of those conditions where every minute matters. If you get the management wrong, the consequences can be absolutely devastating. We're talking about a lifetime of severe disability for your patient.
So in this clinical briefing, we're going to break it all down. First, we'll cover what Cauda equina syndrome actually is. Then we'll dive into the red flags you absolutely cannot miss. After that, we'll talk about getting that definitive diagnosis. And finally, we'll look at the race against time when it comes to treatment.
All right, first things first. Let's build a really solid foundation. What exactly are we dealing with when we say Cauda equina syndrome?
Now, this is probably the most important thing to get right from the very beginning. CES is a clinical diagnosis. It's not something you diagnose from an MRI scan. It's diagnosed based on what the patient is telling you and what you find on exam. The imaging confirms why it's happening, but the syndrome itself, you identify that at the bedside.
So what's causing all this trouble? Well, the usual suspect. The most common cause by far is a massive lumbar disc herniation. But, and this is a big but, you have to keep a broad mind. Literally anything that takes up space in that spinal canal can trigger this. We're talking tumors, abscesses, a bleed, or even a traumatic fracture.
And this is where it gets really interesting. The damage isn't just from a simple mechanical squish on the nerves. That pressure kicks off this whole vascular cascade. It chokes off blood flow, which leads to swelling, and that swelling, you guessed it, chokes off the blood supply even more. Eventually, you get ischemia. The nerves are literally starving, and that's when the real damage is done.
Okay, so knowing how the damage happens helps us understand what to look for. And that brings us to the most critical part of your initial workup, recognizing those absolute, cannot-miss red flags.
This quote from the British Orthopedic Association just hits the nail on the head. Your patient is going to tell you about their pain. That's what they're focused on. They're very unlikely to volunteer, the embarrassing stuff like having trouble peeing or being numb down there. You have to ask the questions directly.
Now, this table might look a little busy, but it's incredibly useful because it helps us figure out just how urgently we need to act. See those stages in the middle? Early and incomplete, or CSE and CSEI? That's the most time-critical window. These are the patients who have the most to lose, but also the most to save with emergency surgery. Once they hit retention or complete, the chances of a good recovery, unfortunately, drop way down.
So these are the big ones, your absolute must-ask questions. If a patient shows up with back pain and the recent onset of any of these symptoms, bilateral sciatica, saddle numbness, urinary problems, bowel changes, or weakness that's getting worse, alarm bells should be going off, loudly. That's your signal for an emergency referral. Okay, so the alarm bells are ringing. You have a really high suspicion for CES. Now what? Well, you need proof, and frankly, you need it yesterday.
And here it is, the absolute gold standard, an emergency MRI. Just look at this scan. You can see this massive disc prolapse that is completely, and I mean completely, obliterating the space where those nerves are supposed to live. It paints a very clear picture, and it's the anatomical reason for what the patient is experiencing.
But what if you can't get an MRI? What's your plan B? Maybe the patient has a pacemaker that isn't MRI compatible. Well, your next best choice is a CT myelogram. Yes, it's more invasive, but it's really effective at showing you exactly where that compression is happening. Now, we also have to talk about CES's close mimic, conus medullaris syndrome. The key difference here really comes down to location. Think of it this way. CES is a lower motor neuron problem. It's an issue with the nerve roots, the wiring after the spinal cord ends. Conus syndrome, on the other hand, is an injury to the very tip of the spinal cord itself, so you'll see a mix of upper and lower motor neuron signs, and it tends to happen more suddenly. So you've got your proof on the MRI. The diagnosis is confirmed. Now, the real race begins. The clock is officially ticking, and this is a true surgical emergency. This is a great example of a national pathway. It's basically the perfect playbook for how to handle a suspected case. You can see it maps out every single step, from the moment the patient walks in the door, to getting the scan, to getting them to the operating room. The whole point of a pathway like this is to do one thing: eliminate delays. Every minute counts, and this makes sure no time is wasted. And this brings us to the million-dollar question, the one everyone in this field debates. Just how urgent is urgent? How quickly do you really need to get that patient into surgery?
For years, the magic number that was thrown around was 48 hours. But the thinking on this has completely shifted. The modern consensus is that nerve damage is a continuous process. It's happening in real time. As Shou and colleagues pointed out, the decline could be fast, and you just can't predict it. So the key takeaway here is there is no safe time to wait. The goal is to decompress as soon as it is safely possible.
So what does the surgery actually look like? Well, it's not a one-size-fits-all approach. For a younger patient with a big soft disc, a microdiscectomy might do the trick. For an older patient with more arthritic changes, a wider decompression, called a laminectomy, might be needed. But no matter the technique, the goal is always the same. Get the pressure off those nerves. Period.
Okay, let's bring it all home. If you remember nothing else from this, remember these 4 things. 1, you have to ask about red flags. 2, the nerve damage is happening right now, it's progressive. 3, if you even suspect it, get the MRI. And 4, there's no safe time to wait. Surgery needs to happen as soon as possible. It really makes you think, doesn't it? What does this push for immediate surgery mean for how we need to organize our emergency services?